السلام عليكم ورحمة الله وبركاته. أهلا بحضراتكم جميعا، وكل عام وحضراتكم جميعا في خير وصحة وسعادة. بمناسبة هذه الأيام الجميلة، العشر الأواخر من رمضان واقتراب عيد الفطر المبارك، الحقيقة أنا بيسعدني ويشرفني أن أكون مع حضراتكم اليوم محمد عبد القادر، برودكت مانجر شركة فاركو فارماسيوتيكالز. في البداية اسمحوا لي أن أنا أرسل رسالة شكر وتقدير لكل فرسان المنظومة الطبية، رسالة شكر وتقدير لكل طبيب على طول خط المواجهة مع كورونا أو الكوفيد 19. شكرا لكل طبيب قدر إن هو يواجه ويعرض نفسه وحياته للخطر في سبيل إن هو ينقذ مريض. شكرا وبالأخص الطبيب المصري المحترم اللي برغم كل الظروف الصعبة والإمكانيات المحدودة قادر بقوة إن هو يواجه بعلمه وبخبرته. شكرا لكل أطبائنا اللي ضحوا بحياتهم في مواجهة كوفيد 19، وبنوجه رسالة ليهم أبدا لن ننساكم. شكرا لحضراتكم جميعا بتشريفنا اليوم في يوم علمي مميز جدا، هو استكمال الحقيقة لمسيرة نجاح تشرفنا فيها كشركة فاركو بالتواصل الدائم مع حضراتكم، واللي بنأكد دايما على رسالتنا بتوفير الدواء المصري بأعلى درجات من الكواليتي وبأسعار مناسبة جدا جدا للبيشنت، وتوفير جود انفايرمنت نستطيع فيها ان احنا سويا نكون على قدر عالي جدا من التواصل والتعليم المستمر. النهارده الحقيقه يوم مميز هيشرفنا بالتواجد معانا اسم كبير، عالم جليل جدا، قيمه وقامه كبيره جدا في سماء علم الانف والاذن والحنجره ENT. بيشرفنا النهارده بروفيسور
دكتور حضرتك، احنا ممكن نعيد اخر جزء ده تاني؟
بيشرفنا بوجودنا معانا اليوم اسم كبير وعالم جليل، قيمه وقامه كبيره جدا في سماء الانف والاذن والحنجره، الاستاذ الدكتور حسام البصراتي، بروفيسور في اوتو راينو لارينجو اند هيد اند نيك سيرجري، فاكولتي اوف ميديسن الكايرو يونيفرسيتي. سعداء جدا جدا بتواجد دكتور حسام. وحقيقه قبل ما نبدا نستمتع بالسيشن اللي هيلقيها علينا النهارده، اسمحوا لي ان انا ارحب بقيمه كبيره استاذنا دكتور عطيه زدان، ناشونال سيلز دايركتور لشركه فارماسيوتيكال. اتفضل يا دكتور عطيه.
شكرا يا عبد القادر. السلام عليكم ورحمه الله وبركاته. انا عطيه زيدان، سيلز دايركتور فاركو فارماسيوتيكال. في الحقيقه يعني بالاصاله عن نفسي وبالنيابه عن شركه فاركو فارماسيوتيكال، اسمحوا لي ارحب باستاذي وصديقي والعالم الجليل الاستاذ الدكتور حسام البصراتي، استاذ الانف والاذن والحنجره بكليه الطب القصر العيني جامعه القاهره. في الحقيقه يعني شرف ليا ان انا اقدم الاستاذ الدكتور حسام لما يحويه من علم واخلاق ومثل عليا. انا بستفيد من كل كونتكست بحتك بيه بالاستاذ الدكتور حسام. وبرحب بحضراتكم جميعا لتشريفنا بالحضور في الفيرشوال لايف ويبينار النهارده باذن الله. في البدايه اسمحوا لي اهني حضراتكم بحلول شهر رمضان المبارك، ومش بس كده، وكمان حلول العشر الاواخر، الايام الفضيله المباركه. واتمنى دعوات حضراتكم لمصر وللانسانيه، ان ربنا ان شاء الله يعني ينعم علينا بالشفاء، وان احنا نتخطى هذه الجائحه ان شاء الله على خير. اسمحوا لي اتقدم ايضا باقصى معاني الشكر والتقدير والاحترام لسيادتكم والاطقم الطبيه المصريه الوطنيه المخلصه على العمل الدؤوب المتفاني في مواجهه كوفيد 19 بانديميك، الى ان نصل ان شاء الله بحضراتكم وبمجهوداتكم، مجهودات وزاره الصحه المصريه والجامعه المصريه، الى بر الامان باذن الله. في الحقيقه التجمع العلمي اللي احنا بصدده النهارده ما هو الا مثال على التعاون المستمر المثمر ما بين شركه فاركو للادويه والميديكال كوميونتي في مصر، في بلدنا العزيزه الحبيبه مصر. Pharco Pharmaceutical is the mother company of Pharco Group, founded by Dr. Hassan Abbas Helmi in 1983. 8 healthcare companies are operating in the pharmaceutical field for development, manufacturing, marketing, distributing, and exporting of a comprehensive array of generics and branded generics drugs under the name of Pharco, along with a rising number of licensed pharmaceutical products. Pharco is the largest manufacturer of pharmaceuticals in the MENA region, focused on research, formulation, manufacturing, and commercialization of pharmaceutical products. Today, Pharco employs over 9,000 employees and has over 750 million packs produced in 2019. Ranked as a leader in the Egyptian pharmaceutical market, Pharco also exports to over 50 countries around the world. Pharco works toward one goal, which is to provide highly effective and safe pharmaceutical products to patients at an affordable price. Finally, as the largest manufacturer in Egypt, we have the duty toward providing safe and effective pharmaceutical products that are within every patient reach. بشكركم على الاستماع ليا وبتمنى لكم التوفيق ان شاء الله والاستفاده من محاضره استاذنا الدكتور حسام. هسيبكم مع فيديو قصير باذن الله وبعد كده تستمتعوا بالمحاضره الثريه من الاستاذ الدكتور حسام باذن الله. شكرا.
Ready?
تفضل.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everybody. Ramadan Kareem, happy Ramadan, Ramadan Mubarak. Inshallah, Eid Fitr Saeed. And I hope that we bypass this area, or this period of the pandemic of COVID safely all, inshallah. I'm glad to be with you today. Thanks for Pharco, one of the most famous, big, respectable company, pharmaceutical company, not in Egypt only, but in the Middle East as a whole. شكرا دكتور عطية, Dr. Muhammad, thank you for the team and for Dr. Rihan, for everybody. Today I will talk about my own experience about mistakes I personally did during my practice of FES. And I try wisely to learn from my own mistakes, to build up lessons. So we can consider this lecture mistakes or lessons. Learn from the mistakes. And I hope that everybody of us can learn from his own mistake and from other mistakes. Otherwise, we are not going to build up an experience in any kind of field of medicine. Let's first start with this cartoon and this wise word. If you do not want to do complications, then do not do surgery. And even I will extend this sentence to involve even do not practice medicine at all, which means that medicine is not free from mistakes, not free from complications. But the condition is that one should know these expected complications or mistakes, try to avoid them, number one. And if they happen, how to minimize these mistakes. And if it happens, how he can control these mistakes. First, as any kind of surgery has its challenges and mistakes. And I will try to talk in most of my lecture in English, and few words I will mention Arabic. Sorry for our dear colleagues from Pakistan or from here and there, because the majority attending are Egyptians and they need sometimes to hear some jokes or some jokey Egyptian words. To start with the patient positioning of the patient. The position is very important. Why? This is one of the positions during FES. This is another. This is a third. Do you imagine what happened? This is the position of the skull of the patient, of the head of the patient during our technique. This is the norm. This is the more flexed, and this is to the more extended. We fix the patients in the supine positions with a tilt 15 to 20 to 25 maximal flexed. But we need to tilt the patient sometimes for certain directions within the sinuses. This, if I need to go to the sphenoid, I need to flex the patients a little bit. With the frontal, I need to hyperextend the head. So imagine, if you go to a particular sinus, but the position is not adjusted, then definitely you are going to pass into another sinus. Could this happen? Believe me, it can happen. And I will show you this photo. This slide, I know that most of the ENT, معظم الأنف والأذن, they do not know what is this. This is what is called the Mayfield headrest. It's used in neurosurgery, but if you cooperate and combine your work sometimes with a neurosurgical colleague, for example, in extended skull-based surgery, you need to fix the head sometimes in this headrest. It allows various tilts of the head. So if you are not cautious about the position of the head, you might have another situations which is going to put you in a hell. For example, in this position, the head is flexed. This is the exact position we worked on FES. But in this position, it is extended. So if you did not notice that this head, if it is put here, is in a hyperextended position, and you want to go to the sphenoid, then to the pituitary, you might go to the ethmoid or the frontal. You will say, هتقولوا, يا دكتور, Dr. Hassan, this is nonsense. What are you saying? Am I going to lose my way? Instead of going to the sphenoid, I may go to the frontal. Believe me, this happened personally with me in my first pituitary case. The head was hyperextended, and I want to go to the sphenoid. I lost my way, and I go to the frontal, and I couldn't realize that except after we put what is called the C-arm to see our tip of instruments inside the frontal and not in the sphenoid. Do you imagine what happened? This was my first pituitary case at 2000 something or 1999. So the position of the patient is the first step to be done. Otherwise, you might practice a mistake. This is very important. So this is a lesson number one. Lesson number two, about the orbital injuries. All of us might got an injury of a structure in the orbit. We have the lamina papyracea and the fat after the lamina. What happened if this occurred? This is the left side surgery, left sinuses. This is the ethmoid, and this is the fat. You noticed here, this is the fat. It's palpating. You press the orbit, you will see the fat popping. You don't need to take a sample of the fat and put it in saline and see if it floats or sinks. No, it appears from the color, yellowish color, from the softness. And if you wrongly take this fat and try to pull, it doesn't come out. It strips additional extras. So don't use it. Don't do that. Just cauterize with bipolar, and that's it, and continue your work. So it's not a matter, but you might expect, ممكن يحصل, what happened is that some ecchymosis, some discoloration of the orbit or the conjunctiva, but no proptosis. The medial rectus muscle, is it nearby or the superior oblique? Imagine this video. This is a combined work between an ophthalmologist through the orbit, and this is the spatula protecting the orbit, and this is the endoscopic view, and this is the spatula you can see here protecting the structures of the orbit, and this is a mass, chronic fungal granuloma. We dissect this mass. Our colleague in ophthalmology is protecting the orbit from outside, and we dissect and bipolarize the mass, and take it out. This is the spatula of the ophthalmologist protecting the medial rectus, and this is his instrument. And we are taking out the mass. You will see the cutting of the mass from, what is this? This is the fleshy fibers of the medial rectus, and we can control. Our colleague in ophthalmology is controlling the movement of the muscle because he's tying a thread around the muscle. So we cut sharply off the muscle to be protected. So this is a possibility that you might injure a muscle of the orbit, particularly the medial rectus or the superior oblique, because both are in the medial position. The anterior ethmoidal artery, I will show you, for example, artery, in this case of mucocele, a long-standing mucocele, and after evacuating the mucocele, this is the orbit, this is the frontal sinus above, and the artery was there. This is the artery. Can you see? The artery is totally in a mesentery, outside the bony canal. So you should be careful when dealing at the roof of the ethmoid, just at the genu of the frontal recess. This is the artery, and you can notice here that it is thrombosed, by the way. Notice the color? It is thrombosed. Why? Because the long-standing chronic pressure by the mucocele slowed down the flow in the artery, and the artery got thrombosed. And this is the orbit. We palpate the orbit, and this is the artery. So you can face the artery unintentionally. You should revise the CT to see where is the artery, where is the level of the artery. Is it in the skull base or in a mesentery or lower down the skull base? You should point that from the CT. The artery itself, you need to expose the artery sometimes, like this case. Why I need to expose the artery? You will see now. You remove the lamina. We remove the lamina in particular in this case. This is the anterior ethmoidal artery, and this is how the artery leaves the orbit and go to the ethmoid. Why we expose this artery? We need to vulgate this artery. We need to cauterize this artery and cut it. Why? To do what is called transposition of the orbit. We displace the orbit to go above the orbit. Why? You will see now, because there was an abscess there. Now we are palpating the orbit. We are protecting the orbit by the side of the instrument, the sickle knife, and then we incise the abscess and the pus comes out. So it was an intraorbital abscess above the orbit, and we need to displace the orbit laterally, and we couldn't displace that except after we cut through the artery, after diatherming or after vulgating the artery with a bipolar diathermy. So this is another situation. What about nerve injury? Nerve injury.
حسام لو تسمح لي،
اتفضل.
الفيديو السابق بس ما كانش واضح او شغال.
Okay, there is a request that this video was not working. Is it working now?
No.
It's working in front of me.
مش واضحة بالنسبة للاتنديز.
Not working?
Yes.
طب the first one was working?
No. proceed. ممكن نحن نبروسيد دي
Okay, I will leave this. I will go to another one and see if there is a problem, technical problem in the third case or not. So this case, for example, this was a child, 8 years, presented with epistaxis, and radiology revealed that there is a skull base mass, as you can see here, in the sphenoid and intracranial, and here is the mass as well. First measures have been done to reassess the child, to treat the epistaxis, to control the bleeding, to assess the child, the bleeding profile, and prepare the child for the biopsy. And we need to do a transnasal endoscopic biopsy. That's it. Okay. This is the child after the biopsy. Well and good. He seems great. But actually, this is not the true picture of the child, because I didn't ask him to move in all directions of the gaze. When you look to the left side, there is squint. So the left orbit doesn't go laterally, which means that, which muscle? Left lateral rectus. It doesn't work. What happened? We should revise ourselves. Actually, the resident told me after the biopsy, please, doctor, come, there is a problem. What's the problem? He said there is something abnormal that I couldn't judge. مش قادر أحكم. I went back and told him, take the child back to the theater and give general anesthesia. I should come immediately and see what happened. intraoperatively. I need to explore the field. And this is the exploration of the field. This is a video. Let me just know, is it working or not?
Not working.
Working or not?
لا مش.
Okay, no, you need to do something. Okay. I'm ready to rearrange the techniques.
Okay.
Okay, I'm ready for the break. Okay.
طيب اسمحوا لنا حضراتكم بس يعني 2 minutes break.
Assalamu alaikum. Sorry for this technical error. We should share what's called the desktop, not the PowerPoint. So back again to the first video, which is just injuring the orbit, exposing the periorbiter. This is the periorbiter. And you should know what happened from the color and from the Stankiewicz sign. It moves, it palpates. When you press the orbit, it moves. So what you need is just to use the bipolar and it will shrink. Don't try to pull it and don't try to use the shaver. No, just bipolarize it. And this is going to give you a space to work through the ethmoid. That's it. And expect minute hematomas, just ecchymosis or redness in the conjunctiva. That's it. What about the medial rectus muscle? I will repeat this video because it didn't work. This was a transconjunctival approach by a colleague. She was an ophthalmologist and she works with me from the orbit. She protects with the spatula the whole periorbita, and from inside, from the endoscopic view, this is the mass. We dissect the mass of the medial rectus, and are you with me? Following? Yes. This is the spatula of our colleague, and this is her instrument. She dissects with me from the orbit, and I dissect from the nose, take the mass out, and you can see the movement. She is palpating the orbit from outside to know our territory, our boundaries, our sharp cut, and then we use the scissor to cut this mass. This was a chronic fungal granuloma, and this is the fleshy muscles. You can see the movement of the muscle. She's pulling the muscle with a thread from the orbit to let me know that this is the muscle, this is the support, this is the sharp cut. You should cut here, as you can see here. So the muscle was very near to us. So it is possible that unintentionally, when you are removing the lamina for an unknown reason, you don't know the lamina has been removed unintentionally, and I work through the fat and I injure the muscle. It happened. Believe me, it happened. So you should take care of the medial rectus muscle if you are going to breach the lamina and go inside the orbit. What about the anterior ethmoidal artery? Again, this video didn't work from the first presentations. Back again. This is a mucocele, a big mucocele, and the long-standing mucocele, after being evacuated, it leaves a big cavity, as if it is a cholesteatoma making a big natural cavity. When you go inside, you will see all the anatomy. This is the cavity. We are inside the cavity now. You will see, just a moment. This is the orbit. No lamina, because the mucocele causes dissolution, resorption of the lamina. This is the frontal sinus up there. And here is the anterior ethmoidal artery exactly in the skull base. No bony canal. There is just a mesentery. And this artery, look to the color, it is thrombosed. Unfortunately, thanks God that it is thrombosed, but not all arteries will be thrombosed, definitely. So you are going to face the artery bare in a mesentery. Take care, because it lies immediately at the genu. Look at the frontal sinus. This is the orbit moving, and this is the genu of the frontal sinus. It's the rukba, the genu of the frontal sinus, when it changes the direction of the skull base from vertical to horizontal. This will be the site where you face the anterior ethmoidal artery. Another case where you need to expose the artery and deal with the artery. This is an intraorbital abscess, and we need to remove the lamina intentionally, and then you will see the artery after exposing the lamina. This is the orbit on the right side, and this is the artery. It's well demarcated there. We use the bipolar to cauterize the artery, and then displace the orbit further laterally, protected by the angle of the instrument, and the tip of the instrument, the sickle knife, will now drain the abscess, the intraorbital abscess up there. So this is, again, an exposure of the artery and dealing or manipulating the artery for a reason inside the orbit. So the anterior ethmoidal artery anatomy should be kept in mind. This is very important. Nerve injury. Let's go and see what happened with this child. This child was presented in the casualty of the pediatric cancer hospital, 57, with epistaxis, 8 years child with a skull base mass, as you can see from the MRI. First measures was done, the first aid measures, and the child was prepared for a transnasal endoscopic biopsy. When we operate the child and take the biopsy in a technique, transsphenoid, which is an easy technique, just biopsy and go out, the child looks great. But this is not the real picture of the child, because when you ask him to move in the direction of the gaze, there is squint on the left side. الولد ما بيتحركش لما بيبص شمال, which means left lateral rectus. What happened? We just go through the sphenoid sinus transnasal. Actually, if I take few minutes and revise this in my mind, I should be sure that nothing happened. But the condition is that the resident told me, come back again, quickly, because I have a problem in the child. The child doesn't move the orbit. I didn't analyze the complaint, and I let my resident to put the child back to the theater, and I re-explore the field. This is the video. I widen the sphenoidotomy and explore the orbital apex, and you will see now the left side. This is the orbital apex. This is the fat. You would see I palpate the orbit. Fat comes out. No blood, no hematoma. The sphenoid sinus, no hematoma. I took even further biopsy, and I find everything normal. What happened? Let's revise what happened. What happened is that this child was having this squint even before he come to us. But the condition is that the analysis of the complaint was not right 100%. The resident didn't assess the vision properly, and the resident, when the child goes out, he didn't ask the parents, does your child have this complaint previously or not? The condition was really confused. That's why I need to convey this confusion to you. أنا عايزكم تعيشوا حالة الاضطراب دي. I want you to think as if you are in this situation. Let me ask you, do you listen to your patient by your resident taking the history, or you to take the history? Please think and answer. None of us, mostly, in the big hospitals, give a chance to himself to talk to the patient. Your resident is the only communication channel. He take the history. He doesn't ask the relatives, because the patient is a child and bleeding. He didn't take time to have and to ask the relatives. He didn't take photos for the child. The child might be blind. The child might be having a squint. How many of us takes photos for your patients? If you are going to do endoscopic sinus surgery, you are going to ask me, why am I going to take photos? Medico-legally, because he might have a squint, and he came after the surgery and said, doctor, oh, you did this for me. You are responsible for this misery. And he sue you. ممكن يرفع عليك قضية. كم واحد منكم consult an ophthalmologist? How many of you consult ophthalmologists? Why to consult an ophthalmologist? Because this eye might be blind, or this eye might be the only seeing eye, and the other one is blind. How many of you ask about the vision, ask about the condition of the orbit for your patients? You are going to operate on them for FES. I'm sure that almost none of us do. And I need you to tell me if you ask for that or not after the lecture. Document after everything. Do your documentation. Do your homework. The orbital hematoma is not uncommon. Actually, it happened. And I know that few of you got through this experience, and I wouldn't wish that none of you go through it, but it may happen, and you should prepare yourself for the orbital hematoma. If it is a minute hematoma, you might notice that just ecchymosis, redness as the orbital fat prolapse, and you injure the fat. That's it. No problem for that. And you expect that the patient is going to awake with this, and after a few weeks, she will be like this, and after 1 to 1.5 months, she's going to be normal. So you should need, number one, to know how to manage this. Because when we are operating this case, look what happened. We are on the left side, and this is the axilla on the left side, and we are using a shaver. This is the middle turbid, and this is the axilla. And suddenly, minimal bleeding happened. We put a bag and then look to the orbit. The orbit was really tense. By the way, the nurse noticed that, not me. And this is very important when we drap, لما تحط الفوط, drap the patient, let the eyes to be exposed. You need to see the eyes. And you just put like a cream or an ointment to protect the cornea, but you need the eyes to be exposed to feel the tension, to see the proptosis if it happens, to see the color. Actually, the nurse told me, doctor, notice the eye. Something happened. Yes, the eye was tense and discolored. And look to the bleeding. It was trivial. It was minimal. يعني حاجة لا تذكر. حاجة بثلاث تعريفة زي المصريين ما بيقولوا. ولكن this injury, minute injury, trickles inside the orbit and makes a preseptal hematoma. We just cauterize. We remove the lamina. You can see the popping, the Stankiewicz sign. We decompress the lamina, and we expect that this patient is going to have a hematoma, but we reassure her, we reassure the relatives, we expect that, don't worry, it's going to resolve within a month. By the way, expect that within a month. Don't put an expectation that it's just a week. No, you should be honest. And do not expect that to happen except after about 1 month. But everything is going to be normal, as you can see here. Another case, look to these situations. What happened if you are operating for a patient like this, and then you do the hematoma? You are the cause of the hematoma. The child is not, or this adolescent patient of 20 years old, maybe 21 years old, he was operating for a recurrent case of a mucocele. This is the video. This is the middle meatus on the left side, and this is the access to the frontal. It was blocked by adhesions, and then we find our way to the frontal recess, look to the starting coming mucocele. It was a very, very targeted, very quick approach. This is the approach to the frontal. It seems to be easy. But actually, the problem here is that the frontal was multicellular. There are multiple cells within the frontal sinus. So once we go inside, you will see, is this the frontal? No, this is not the frontal. This is a cell, and you can see here movement. We are palpating the frontal table because it was very thin. It pops. It makes a movement. This is our natural navigation without an image guidance. Just to do this or just to palpate the orbit, okay, we find, yes, this is the access to the frontal, but we need to widen this. Imagine that you are above the orbit, going up in a hyperpneumatized frontal sinus. The area is remote. It's far away. You need a long instrument, you need curved instruments, you need the properly adjusted instruments to operate high up. And during our operations, we need to remove part of the medial orbital wall, medial and superior orbital wall. But once we are going to do this, we experience some bleeding. You will see now what happened. There was some bleeding, and we noticed that the eye got proptotic. So we expect that we injure the fat of the orbit, and some bleeding occurs inside the confined orbital wall, and a hematoma has accumulated. So we need to decompress. This is now the frontal sinus, and this is the orbit. We remove the lamina. This is the lamina being removed. And finally, you will see the fat popping out. The pressure has been relieved. This is the medial decompression. And then we shift to the lateral canthotomy and the inferior cantholysis to decompress the orbit medially and laterally. What do we expect? We expect this after a few days. We expect this. We expect this gradually, gradually, and gradually. You don't need to expect that this patient is going to see the same night or the next day. Definitely not. He's going to awake with no PL. And then next day, he's going to be almost hand movements. Few days later, he will be counting. Few weeks later, he's going to regain his vision to normal. This is very important. Don't be panic that he has no PL immediately after he awaked. You should here have your ophthalmologist beside you to reassure you and to make sure that the ipsilateral, the contralateral reflexes, he should calculate that and monitor that, not you, not the anesthetist. You are in a situations. The anesthetist is not specialized. This patient is under general anesthesia, is under analgesia. The pupillary reaction is not properly seen. So expect a very weak and delayed response. So sometimes you as otolaryngologist or the anesthetist is not going to predict the minor change of the pupillary reflex. So you need to consult the ophthalmologist. What are the lessons? The lessons are, number one, you should use the proper instruments. You are high up in the frontal, you should use long curved instruments. You should have the navigation system, either the natural or the true navigations, the image guidance techniques, because not all the time you have the image guidance, but you should navigate by your own tools, but by the natural tools, by the CT landmarks you have already seen and oriented in your brain. Do not hesitate. If you need to take a step or to do a job, do it. Don't waste time, because with hematomas, you have limited situations, you have limited minutes, you have maybe 2 hours to operate on the optic, on the deceased, on compressed optic nerve. Otherwise, the patients might lose the vision. Think by your brain, not by your heart, not to be sympathetic and said, oh, should I take the patient again to the theater? Should I wait? Who is going to pay? If it is private, مين اللي هيدفع? Don't think of these. You are dealing with the critical situations. You are dealing with a vision, with an eye. And imagine that you might be the cause of this patient losing vision. Take the decision with confidence. Consult oculoplastic surgeon. It's very important. And after all this, document. Write it down and document with photos as well. Some relaxations. Dealing with the crocodiles. This is the Louisiana crocodile in America, and this is the Nile crocodile. Look to the difference. طبعا ايه دهن في العتاقي عندنا في النيل crocodile بتاعنا حاجة عظيمة جدا. You should learn how to deal with this and deal with this. Okay, stepping to another situations, another mistake with dealing with the frontal sinus. Frontal sinus is the most difficult sinus to be dealt with.
Sorry دكتور حسام لو تسمح لي بس just a comment بالنسبه لنا لو اي دكتور او if any doctors need to ask any question.
Yes. If any questions in the previous slides, I'm ready. Okay. Please
click ask a question button below a video streaming and you can ask any question. Thank you. تمام ready يا دكتور كمل انا بس just بقول.
Okay. Continue.
Yes.
Okay. With the frontal sinus, this is a patient having a fractured posterior table in the frontal sinus and CSF leak. She's dribbling here, as you can see here. This is, as you can see, there is a drop of water coming from CSF from the right side. So this patient has a right CSF leak due to posterior table of the frontal sinus fracture. This is the surgery. Look what happened. And there is a mistake happened during our exposure. This is the injection of the fluorescein, and we trace the fluorescein. We approach the frontal sinus. Let me show you what happened. This is the frontal recess, and you can see the meningoencephalocele there, the greenish or the yellowish green, discolored meningocele up there. Okay, we need to shrink this meningoencephalocele. Actually, we use something. I will show you what's the tool you used here, which is not the proper tool. This is a unipolar suction. We isolate it and we do the cautery there. You will see what happens. I need you to see the burn which happens. Look to the fire again. The burn was so extensive. Look to the fire, what happened there now? Have you all seen the fire? Okay, we didn't actually carry much a problem, and we noticed that we tell ourselves that this is not going to make a problem, continue, and we found that it's wise to use the bipolar. We continue the vulgarization of the meningocele with the bipolar, and we continue everything. And finally, we chose the reconstruction with the fat. This is the piece of fat you will see now. This is the defect after we remove the meningocele. A piece of fat has been put, and after the fat, we take fascia lata, and we put this fascia lata underlay technique to seal the defect. And it's very important when dealing with meningoencephalocele in the frontal recess is to reconstruct without, of course, closing the frontal drainage pathway, because you need this sinus to be continually aerated and drained. So you need this technique to be underlay technique. So we are successful in doing that. What's the problem? The problem is that the patient next day came out with this. And when we consult, by the way, the ophthalmologist, thanks for him, he said, oh, this is an orbital hematoma and she needs decompression. Sorry for, I don't have a picture or a photo for this lady if I try to open the eye, because there will be no hematoma if the orbit is not proptotic. This is just lid edema. And I expect to have lid edema in any cautery near the orbit, unipolar or bipolar, but in particularly the unipolar with the charring effect has much worse effect, of course, and with the results in severe edema. But we didn't do anything except the conservative measures. We didn't decompress the patients. We just put the cold fomentation in the first 24 hours and continue for the hot fomentations and the anti-inflammatory for the next few days. And then this is the patient. So the problem is that the unipolar near the orbit or near the skull base shouldn't be used. You should use bipolar diathermy and in a low temperature, low intensity, not even very much powerful electricity. This is very important. I'm ready if any questions has been raised up. So we take some problems and some mistakes in dealing with the orbit. We talk about mistakes in dealing with the frontal sinus. What about the maxillary? Some of the colleagues will speak and say, oh, maxillary? Is the maxillary a site for complications? Are you sure, Dr. Hussam? Maxillary sinus, the easiest sinus, can result in complications? Well, believe me, I don't feel that the maxillary sinus is an easy sinus. We underestimate the maxillary sinus. And let me show you this case. This was a case with a meatoquanal polyp. It's a polyp coming from the meatus on the left side and filling the quana, and there is just mucosal hypertrophy in the maxillary sinus. This is the video for the case. It's a piece of cake, a very simple and easy job. This is the left side. This is the inferior turbinate and middle turbinate. We wash, and you will see the edema on the meatus and the polyp strangulated here in the quana and coming from the meatus. That's the polyp. We just take the polyp out, as you will see now. This is the polyp. It's a straight ahead procedure, doesn't take much time. And then the meatus, we tried and we decided to make an ansenectomy and just a middle meatal antrostomy, and that's it. And we were satisfied of doing just a small opening there, and we felt that everything was finished. That's it. Okay? I will not take much time with this. I will show you the patients after maybe 1.5 months. This is the CT. What happened? Is it possible to have this sinus? Look to these patients endoscopically. I take her back to the theater. Look to the sticky secretions on the left side coming from the ostium there. And see, if I try to make suctions by the suction tip from here, you will see something from there. You will see another opening draining there. This is an opening and this is another. So we have two openings. So it is recirculation inside the maxillary sinus. This is the problem. This is the condition. Is that look to the mixed, even fungal infections coming out. So it was a misery. What happened is that we failed to communicate both ostia. We didn't either. We didn't open the natural ostium, and we were satisfied just to widen the accessory ostium. Or if you open even the natural ostium and you didn't take care of the post-operative care of the patients, you might have adhesions happening, and these adhesions might even divide the wide ostium into two. So there will be recirculation. It's very important to make sure that you communicate the accessory with the natural and results finally in a single, non-circular, non-trimmed all around. You should keep healthy mucosa in part of the circumference to prevent restenosis and fibrosis. And the care is very important post-operatively. And this is the patient's early post-operative with good aeration and reasonable drainage. So it's very important to put in mind the possibility of the second or the two ostia. The same situations happened with this doctor, by the way. He was at that time a house officer, and he came to me with this CT and with this MRI. And this patient had been operated 1 year ago with bilateral turbinectomy. He went to a doctor and said, I have nasal obstructions. The doctor trimmed the turbinates, and that's it. But the patient didn't improve. And he came, I asked for a CT and MRI, and that's we have. That's what we have. عنده طبعا واضح cyst. There is a cyst. And the cyst carries heterogeneous contents. Actually, it was a congenital cyst. It was an enamel cyst called keratocyst, or what is a misnomer of that, or a synonym is a cholesteatoma. There are many synonyms. There are many names. Cholesteatoma, keratocyst, enamel cyst, many actually terminologies. Look to the patients to see the phenomena of the two ostia. This is the CT and this is the MRI. Go to the directly. This is the bulging lateral wall. Look to the secretions coming from here, and there we have two openings, as you can see, and filled with this cheesy material, as you can see. We press to evacuate it and to decompress the cyst and to have a place to work. And finally, these are the openings. You can see here, this one opening, and this is the other opening in the keratocyst. So we evacuate the contents and we remove extensively the medial sinus wall, and finally have a big natural cavity, exactly like you are doing a radical mastoidectomy in case of cholesteatoma. We remove the matrix, we remove the contents, we remove the wall of the cyst, and finally we have in the floor, this is the base of the tooth, or the root of the tooth, as you can see here. That's the tooth, which is erupted already and having no problem. So we left this, otherwise we are going to have an oroantral fistula. So we keep this. This is the tooth, as you can see. This is what is called like a radical medial maxillotomy, like the radical mastoidectomy in ear surgery. 9 years later, I will show you, he came back during an attack of infection, and this is the crustaceans, this is the secretions. He's in the outpatient, he's awake, and without anesthesia, just we make the suctions, we make the cleaning, and everything was normal. And this is the healing on the teeth, over the root of the tooth, and the patient is swallowing, as you can see here, a little bit irritable. And this is the healing. It is marvelous. It is wonderful. Exactly like the way you have a radical mastoidectomy and you have a keratin kept or left, or appearing later, and you can do the local debridement in the office. So this is was the proper management for this case of enamel keratocyst. And I brought this case to show you the idea also of the two foramina. When there are two foramina in the maxillary sinus, you will have reinfection, and reinfection. So what we learned from these two slides about maxillary cases is that make sure that you communicate both the natural and the accessory ostium. Avoid circumferential widening of the ostium. You should leave normal mucosa. Ask for a CT before any nasal surgery. This is a question. Do you ask for a CT before turbinate surgery? Do you ask for a CT before septal surgery? I'm sure that maybe 80% of us does not ask for this, which is wrong, because this second patient had been operated 1 year ago by with turbinectomy, and he didn't at all, he wasn't a candidate for turbinectomy. What he needs is to eradicate and remove this cyst, but he had been operated without a CT. Again, take care of the adhesions post-operatively. So this is the lesson I learned from these two cases of medullary sinus. Yes, I will stop here to hear about questions, because we are going to the sphenoid.
Just doctors, feel free, you can ask any questions and leave your comments in below chat box, so you can answer any questions. And at the end of this webinar, please claim your certificate and answer questions to receive a certificate by mail. So please, you will find a blue button here under the chatting box. You can claim your certificates. So if any questions, you can ask here. Thank you. هي كل الكومنتس يا دكتور حسام كلها شكر الفيري انترستنج والفروتفول سيشنز، فاحنا في انتظار ان شاء الله كده.
But we need questions. Questions is the fruits of the session. Okay, till you prepare yourself, should I continue?
Yes.
Sphenoid sinus. This is one of the most interesting cases I have. I remember this lady by name, and she's now my friend. She is at the age of about 70 years old, but at that time she was about 56, 57 when she came to me with this CT and clinical presentations. You know that unilateral CT opacity, as you can see from the coronal and the axial, and the soft tissue window here, you can see the mottling. And with the sagittal cut, you can see the mottling and you can see the defect in the sphenoid sinus. It's very clear. Again, the soft tissue here, you can see the soft tissue opacity, which means that, طبعا انتوا كده عارفين لما يبقى عندنا soft tissue density with double densities. Again, if you have a double density in the bone windows, it appears soft tissue, and in the soft tissue, it appears hyperdense. This is a diagnosis of a case of allergic fungal sinusitis. Well and good. In most of these cases, it's an easy case. The mud is extensive every there. You need to wash, irrigate, and clean everything. Most of the cases, it's simple, but take care about the areas of the dehiscent dura. It's very important, like here. What happened in this case is that there was a self-confidence. Too much self-confidence. You will see now. After cleaning the maxillary, the ethmoid, and everything, we are trying to open the sphenoid. And look what I'm holding. I'm holding an osteotome. And I open the sphenoid. Do you notice something? Is this the sphenoid? This is a washout sign. The washout sign, this is the sphenoid. So the sphenoid is there. It's below. It brings a bubble of air because it is an air-filled space with some debris, of course, of the fungal. But this is the problem. Here is the problem. The problem is that we do something hard. Let's discuss what's this. Did we open the sphenoid or the skull base or the orbit or the posterior ethmoidal? No. It is definitely the skull base. Skull base has been opened because we should use, what's the proper instruments that should be used? Should we use the giraffe? Should we use the Blacksley? Should we use the suction or the mushroom forceps? I will answer for that. It's more, of course, better to use the mushroom forceps. How to deal? Should we repair the skull? Or should we do what? Actually, the problem is that, let me see back and show you back the video, because there is another problem happened. Not only the skull base has been opened, but look what happened. This is the maxillary, this is the sphenoid, this is the defect. See what is there in the defect. This is the sphenoid. I remember the exposed dura. This was the exposed dura, as we can see. But see in the defect, what's that? You will see there. There is a vessel. There is an injured artery. And you will see the spurter now. This is an artery. What happened? We do a double injury. We remove the bone of the skull. We injure the dura, and the vessel has been torn. There is a real problem. So you need first to cauterize the vessel, because it's meningeal vessel, not a major one. And after making sure with a normotensive, you should elevate the blood pressure to make sure that the artery is sealed. Otherwise, you are going to reconstruct on a bleeder inside the cranium, and the patient is going to awake with intracranial hemorrhage. She will not awake. She will die, of course. So we cauterize the artery. We make sure that the artery is sealed. We plug with fat. We put a piece of fascia, and you can use a glue. And Surgicel is put. Everything was fine. And remember that you are reconstructing the skull base above the sphenoid sinus. So don't close the sphenoid sinus. The sphenoid sinus is there, is below the reconstruction. So the reconstruction is above. Everything is sealed. And we put a pack, and everything was fine. And the patients went in a wonderful post-operative view. Everything went fine. But 2 months later, that's why I said that this patient was really interesting. 2 months later, she came with this. What is this? When I asked her to look to the right side, she looks to the right. This is good. But when I asked her to look to the left eye doesn't go left. Which means, which muscle? أنهي عضلة? Lateral rectus. Left lateral rectus palsy. Let's revise. خلينا نراجع. هو احنا عملنا العملية فين؟ The operation was at which side? It was, yes, on the right side. The surgery was on the right. And the patient is coming now with the left, and 2 months. Anybody has a reason? Has an explanation? Is it delayed hematoma? Nonsense. It's the opposite side. Is it spreading infection? Again, nonsense. It is sympathetic ophthalmoplegia. It is unrelated. Would you like to answer, or leave the answer for you? Being a lecture and not a quiz, it is unrelated. I was giving this lecture once, and I think a guy from India, he said to me, from the audience, he said, I asked, is she diabetic? And he was smart. كان ذكي جدا. He knew that this lady was having a diabetic neuropathy. It is neuropathy of the abducent sixth cranial nerve. It is an isolated neuropathy. We all might face vagal neuropathy. We all have cases of idiopathic vocal cord palsy. We all met cases of Bell's palsy. Why not to have idiopathic sixth nerve palsy? اشمعنى يعني السكس نيرف اللي على راسه ريش؟ ما هو السكس نيرف زيه زي ال7 زي ال10th. It might be affected with neuropathy as well. So this patient was having a sixth nerve palsy due to neuropathy, due to being diabetic, and this is the patient after the management. She's wonderful. She's back to normal. So this was a very, very, very interesting case. I learned from the surgery, and I learned from the post-operative sequelae that happened. Stop for a while and hear from you if there is any questions. Otherwise, we will continue. أنا معاكم لغاية بالليل، لغاية الفطار، بس الفطار على حساب محمود ريحان. حساب على حساب الفطار على حساب.
حقيقي في معظم الكومنتس اللي جايه لنا out of thanks for this great and fruitful interesting presentations من معظم الزملاء والاطباء. فاحنا we are waiting انه any question. You can feel free. You can ask your questions and leave your comments in the below chat box.
Okay. Till I hear any questions, I will continue. Still, we have wonders in the sphenoid. شوية حاجات برضو درر. Okay. When you need to open the sphenoid, we all know that you should know where is the quana, and you should go above the quana by 1.8 centimeters. This is the average. It's a persistent and a constant landmark. You cannot have cases no quana. All the cases have a quana and have a superior lip. This is the most constant landmark in opening the sphenoid sinus. Of course, if there is a superior turbinate left, it is parallel to the lower third, just behind and medial to the lower third of the superior turbinate. The landmarks. The medial orbital floor. Again, the medial orbital floor is a landmark for the sphenoid sinus. Very, very important, medial orbital floor. Okay. If you operate in cases of quanal atresia, this is an interesting case of quanal atresia. This is the right-sided atretic quana, atretic plate. This is the septum. And these are the steps of the surgery. We inject the adrenaline, we put a pack, of course, saline adrenaline, 1/200,000, and we elevate the mucosa, and this is the vomer. And then we start drilling and removing the vomer, keeping the flap intact as much as you can. And see what happened. This is the atresia. See how thick is the atresia. Sometimes you might lose your way. Please look what happened. We are using the drill, suction is there, an endoscope is there, so we have 3 devices, 3 instruments inside, and of course irrigation every moment with the assistant or a nurse. And all of a sudden, look what happened. We open something. Unfortunately, that we open a pneumatized sphenoid. This child was 6 years old, and this was a pneumatized sphenoid. Otherwise, if there is no pneumatized sphenoid, you might what? You might endanger and breach the skull base and results in CSF leak. So look again down and continue the atresia, removal of the atresia. Look to the atresia, look to the opening. This is the open of the sphenoid, and this is the atresia now widely opened, and we remove part of the vomer. And you can see now that this is the whole nasopharynx is seen, and this is the pack of pharyngeal pack put by the anesthetist. So we have a wide quana with the sphenoid sinus ostium open. So what happened is that, and what is the lesson? You need, number 1, to stick to the floor of the nose. This is very important. Start medial, then widen lateral. Use the 0 degree in most of the cases of the quanal atresia, and when you shift to the angled, be sure that you are using an angle. Don't forget that. The image guidance, if possible, if available. These are the points and the lessons and the things that you need to remember in operating on quanal atresia surgery. Now shifting to another title. Still asking. Any questions?
No question. بس احنا قدامنا 2 minutes يا دكتور. دلوقتي الساعه ما شاء الله، يعني التوبيك كانت very interesting، هي استفدنا منها كلها، بس احنا قدامنا 2 minutes.
We have only 2 minutes, so I will not wait for the questions. I will leave the questions at the end. Okay, epistaxis. I need just to stress on certain points about epistaxis. Number 1, it's better to manage cases of epistaxis during the attack, which means that if you have a patient bleeding, it's very nice because you are going to see by your eyes, where is the bleeder? This is simple. Look to this patient. He's coming with bleeding, and fortunately, you put the scope and we see a spurter in the floor of the nose after turbinectomy. This is the spurter. So this is very important to see that, and we cauterize it simply. So this is very important. Another thing is that explore the nasal mucosa all around. Don't rush for a major vessel ligation, for sphenopalatine artery ligation, except after flooding the nasal mucosa and the whole nasal cavity with irrigation. Because, look to this case. This was a patient's I did for him sphenopalatine artery ligation, and this is the removal of the pack. He asked me to remove the pack under general anesthesia, and this was the will of God. Alhamdulillah, دي كانت إرادة ربنا إنه he asked for that because he was exhausted. So I take him to the theater, I give general anesthesia, and this is the nasal cavity. I'm cleaning because he's under anesthesia. I'm washing. Everything was normal, was perfect, no bleeding. But look to this area, high up in the nasal cavity. We are on the left side. This is the lateral wall. This is the turbinate. There was a clot between the neck of the middle turbinate and the septum. I go behind this clot, I irrigate, and there was a spurter high up there. You will see the spurter immediately now. This is the spurter. It's just above the neck of the middle turbinate on the septum. This is a branch from the anteroidal artery. And I go to ligate the sphenopalatine. This is something else totally different. The patient was going to bleed again and again. So it is very, of course, I cauterize the vessel and I finish the story. But the message is that explore the nasal mucosa all around. Try to irrigate, clean, and before you go to the sphenopalatine, you might have another bleeding coming from elsewhere. So this was a very important step. I think I finished in the 2 minutes.
Yes.
Still I have more, and I know we have restricted time. عايزين نروح للفطور. فطور, I don't know فطور in Pakistani, what does it mean? We need to eat, inshallah, after 20 minutes maybe. So we are ready to close up.
Yes.
I'm glad to hear from you if any questions are there.
شكرا دكتور حسام for this very interesting sessions and fruitful sessions. حقيقي بشكرك، قيمة وقامة كبيرة جدا جدا جدا، عالم كبير جدا.
Thank you محمود، شكرا.
للأنف والأذن حقيقي بنشكرك على وجودك معنا النهارده، ويعني بالأصالة عن نفسي وبالأصالة عن كل تيم فاركو بنشكر حضرتك على تواجدك معنا، وبنشكر كل السادة الزملاء على وجودهم معنا النهارده في يوم مميز جدا جدا. كل سنة وحضراتكم جميعا طيبين، وأشكر تواجد وتشريف حضراتكم معنا النهارده. شكرا جزيلا دكتور حسين.
شكرا محمد، شكرا جزيلا، كتر خيرك.
شكرا جزيلا.
Thank you.
شكرا.